So good morning, everyone. I'm here with Dr. Stephen Sears and Dr. Corey Anderson, an OBGYN from Northern Light Health. And Corey has agreed to join us to talk about issues related to pregnancy, fertility, breastfeeding. We know questions have come up from patients periodically about that, about the vaccine. So we're going to appreciate her willingness to join us and expertise, and we'll be going to her in just a few minutes. As always, if folks want CME, send an email to covidcme.dhs.gov. We have no financial relationships to disclose. We are going to talk a little bit about some vaccine updates, which Dr. Sears tells me has been updated even since these slides were made yesterday evening. So he'll give us updates, and then again, concerns in pregnancy, and then some additional updates to the state's vaccines priorities. Steve, I'll turn it to you. If everybody's familiar, I think, with this slide summarizing the current three. So maybe I'll just go right now to
Yeah, I
AstraZeneca.
think the most importantly, yesterday, AstraZeneca had a press release, which was then sort of re-released by a number of organizations, showing that their efficacy appeared to be 79% in protecting against symptomatic disease and 100% in severe disease and hospitalization. The trial, as you can see, included this many people. There did not appear to be, I think probably importantly, there did not appear to be safety issues. There's been a lot of press noise about this in Europe, but it's not actually been shown by the European Safety Board as well as the Data Monitoring Safety Board to be associated with the vaccine. It can be stored at regular temperature. I think the big update is last night, the Data Monitoring Safety Board, and again, just to put this in perspective, we do a double-blind controlled trial. The people doing the trial don't know who's getting the vaccine. A Data Monitoring Safety Board is the organization that is non-biased, not part of the company, that is overseeing the data and determines when it is okay for data to be analyzed, because there appears to be a benefit and or not. The data monitoring, and so this press release came out yesterday. The Data Monitoring Safety Board last night said, wait a second, we're not sure you're analyzing exactly the right data. They did not come out and say that the efficacy is less or more or anything else, but that was released last night, and there now is some question as to whether this is going to be what we see as far as efficacy. I think this will play itself out today. But I think, as always, it's important to remember when something is a press release versus actually data. And we'll see this data most likely when this is sent to the FDA for their analysis, and then the EUA, if that is granted, will be published and we'll have access to all the information. So I would expect more to come, as well as a lot of noise in the press today. Next slide. I think we've seen this slide too. The most important point is, if you look on the left, you've got the six vaccines: Moderna, Pfizer, Johnson & Johnson, AstraZeneca, Novavax, and Sputnik. Sputnik, we're not going to see in this country. All of these others, we have Moderna, Pfizer, and J&J. AstraZeneca, as I just said, we may be seeing that in the near term, maybe not. Novavax, I think, will be coming out towards the end of April. They're all different types of vaccines: mRNA versus viral vector versus a spike protein, which is Novavax. Importantly, look at the yellow part of that, and these vaccines appear to be very effective against severe disease, hospitalization, and death, and that's really what we're looking for. They're all also effective against symptomatic disease, but that they'll have different efficacies depending upon the vaccine, the time the vaccine trials were done, the populations they were done in. But the good stuff is that these are really effective vaccines. And that's just a quick summary, and I'll be happy to take questions at the end, but I really want Dr. Anderson to talk about pregnancy.
Great, thank you. Yep, so we'll switch over to Corey if you want to jump in.
Sure. Hi. So my name's Corey Anderson. I'm an OBGYN at Northern Light, and full disclosure, this is a very personal and close issue to me. I am currently 29 weeks pregnant, and I did receive the vaccine during pregnancy. So I've done a lot of in-depth look into the vaccines. So I think we should start out by saying or emphasizing that pregnant women who have COVID-19 and show symptoms are more likely to have severe disease than non-pregnant women that are symptomatic. And they're more likely to need intensive care unit level care, more likely to need a ventilator, more increased risk for needing ECMO, and more likely to die from the illness. So this is something in the OBGYN world that we've been paying very close attention to. Pregnant women with some health conditions such as diabetes, obesity, hypertension may have an even higher risk of severe illness when compared to non-pregnant women with these conditions. And pregnant women who are Black or Hispanic have higher rates of illness and death from COVID-19 than other pregnant women. And this kind of goes to our increased risk in pregnancy in general in our Black and Hispanic population, not necessarily because of biology, but because these women are more likely to face social health and economic inequalities that put them at greater risk for illness. So researchers have found a few cases of COVID-19 that may have been passed to a fetus during pregnancy, but vertical transmission does seem to be rare. But what we do know is that a symptomatic woman has an increased risk of preterm birth and stillbirth. And so there is increased risk to the fetus in these situations. So pregnant women may choose to get the COVID vaccine currently. There's a limited amount of safety data available on COVID-19 during pregnancy at this time, but what experts know so far is very reassuring. The tests done before the first vaccines were approved for emergency use did not include pregnant women, but based on how the vaccines were made and the science behind the vaccines, experts believe that they should be safe in pregnancy. The CDC and some COVID-19 vaccine makers are now starting or planning tests with pregnant women. Based on the mechanism of action of these vaccines and the demonstrated safety and efficacy in phase 2 and 3 clinical trials, it's expected that the safety and efficacy profile for pregnant individuals would be similar to non-pregnant individuals. And excitingly, to date, over 30,000 pregnant people have self-reported to the VSafe CDC program, which collects outcomes including miscarriage, stillbirth, pregnancy complications, maternal ICU admission, adverse birth complications, neonatal death, infant hospitalization, and birth defects. The adverse events observed thus far do not indicate any concerning pregnancy outcomes, pregnancy complications, or neonatal outcomes when compared to background data. The most common reported incidence in this system was miscarriage, but the miscarriage rates are not elevated beyond the background risks of miscarriage. And then the adenovector platform used in the Johnson & Johnson vaccine does not contain preservatives, it does not replicate in the cells, and based on ongoing clinical trials of this type of vaccine for COVID-19, HIV, and Ebola, when administered to pregnant individuals, it is believed that they have a safety profile without significant issues as well. So some of our big governing societies have come out with strong statements in support of offering the vaccine to pregnant women. The American College of OBGYN recommends that the vaccine should not be withheld from pregnant individuals and that it should be offered to lactating individuals in a similar fashion to non-lactating individuals. They emphasize that there's no need to stop breastfeeding if you get the vaccine. And say if you are trying to get pregnant, you should get the vaccine. The Society for Maternal Fetal Medicine, that's our high-risk OBGYN society, they strongly recommend that pregnant and lactating people have access to the vaccine. And then interestingly, the American Society for Reproductive Medicine, so that's our reproductive, endocrinology, and infertility physicians go so far as to say patients undergoing fertility treatments and pregnant patients should be encouraged to receive the vaccine based on eligibility criteria. And they say that since it is not a live virus, there's no reason to delay pregnancy attempts because of the vaccine administration or defer treatment until the second dose has been administered. And then the University of Washington has a voluntary registry. So we are encouraging any woman who becomes pregnant or was pregnant prior to receiving the vaccine to go online and join this study. And then I'm always encouraging all of our pregnant women and lactating women to join the CDC Be Safe as well. So you've probably heard there's many myths and concerns that are floating around the media and social media, and our patients are coming in with many questions regarding the vaccine and fertility. So there is absolutely no evidence that the COVID-19 vaccines reduce natural fertility. And I think, unfortunately, this is a common scare tactic that we've seen in people who are against vaccines. And a lot of it is very reminiscent of what we heard with the HPV vaccine when that was rolled out. So there's several strong reasons that we can dispute this theory. The first being those with natural COVID infections also form antibodies. And it does not seem that we're seeing an increased risk of first trimester pregnancy loss. The claim behind a lot of these fertility scares is that the COVID spike protein and the syncytin protein of the placenta share 5 amino acids in the same order. But if you break it down, the spike protein is 1,273 amino acids and is a trimer. The syncytin protein is 538 amino acids and is a dimer. No one who has spent time studying immunology is making this argument in good faith. And we know infertility is a common fear tactic for those who are against vaccines. So again, no evidence that it reduces fertility or has any harm to a pregnancy. So the current recommendation is that there is no reason to delay conception to those who are getting the COVID-19 vaccine. If women become pregnant after receiving the first dose of the vaccine, they should not delay getting the second dose of the vaccine. A theoretical concern that has come up is the fever that follows the second dose of the vaccine. We know about 10 to 15% of recipients are reporting this. And in pregnancy, there have been studies, animal studies, that have shown that high fevers in early pregnancy might be associated with an increased risk of birth defects and pregnancy loss. So how I counsel my patients is if there is a concern, they should take a fever reducing agent, Tylenol, after receiving the vaccine if they start to become symptomatic. And if undergoing fertility treatments, the current recommendation is to continue treatments and to receive the vaccine. And as always, we're really encouraging a patient-centered discussion and joint decision-making with regard to the vaccine. It's a personal decision, but our goal is to have these women have the best information available to them. Next. And this is just talking a little bit about maternal antibodies. So there's exciting research coming out right now. So there was a study recently published that showed a transplacental transfer of maternal antibodies. So this was in asymptomatic and symptomatic infected women during pregnancy. The cord blood antibody concentration correlated with maternal antibody concentration with duration between onset and infection and delivery. And then there's some very new research coming out right now that is showing that pregnant women who received the vaccine are passing on a vaccine mediated immunity to their newborns. And we are seeing it in the breast milk as well. And then to focus a little bit on breastfeeding. So American Society for Breastfeeding Medicine does recommend that women receive the vaccine while breastfeeding. And any small amounts of mRNA or DNA from the vaccines are quickly broken down in the maternal system. It's extremely unlikely that any vaccine material would get into the breast milk or be passed to the fetus through the placenta. And additionally, because the material is so easily degraded, it cannot survive the acidic environment of the baby's stomach, even if it were ingested. So we are starting to get actual confirmation of our hope that the women who receive the vaccine are passing on these antibodies to their newborns.
Great. Well, thank you so much, Corey. And I think Amy Belisle, we wanted to talk just on this theme of maternal and child issues related to vaccine. So we'll take questions in just a minute, Corey, but thank you so much for going through that. Amy, do you want to talk just for a minute about vaccines in children?
Thanks, Lisa. Thanks, Corey. So currently there is one vaccine that's available for older youth older than 16, which is the Pfizer vaccine. For those that are older than 18, they can get the Moderna, J&J, and the Pfizer vaccine. We do have their trials underway right now. Both Pfizer and Moderna have fully enrolled trials for children under the ages of 16 and 18. And Moderna has just opened up trials for the 6-month to 12-year age group. We have looked around. Most of the trials, I think the closest one to us is in New York. Most of the trials for Moderna are on the West Coast. J&J has started to open up trials for the 12 to 18-year-olds, and then they'll start their trials for 6 months and older. I will note that Pfizer also has a trial that is currently open for pregnant women as well. So I think that we don't know the definitive time frame for when the vaccine is going to be available for younger children. I think we're anticipating that hopefully by end of summer, in the fall, potentially there will be one vaccine that's available, but we just don't know the time frame yet on that. And so I think if you're at a vaccine site or vaccinators, and when the state does open up vaccine eligibility for all age groups, it is something to think about, that we'll probably need to have sites look at how do they get their 16 to 18-year-olds in there for the Pfizer vaccine until the other trials have been completed. So I'm sure that there will need to be some special consideration for that age group to make sure that they're getting the appropriate vaccine at the appropriate intervals.
Great, thanks, Amy. And then I'll just remind folks of a few updates from the state side of things. I mentioned last week, well, actually, we didn't have the Tuesday session, did we? So if anybody was on the Friday call, you might have heard me say this, but the state is now offering free transportation to anyone needing a ride to a vaccination appointment. It is the organization Motive Care, formerly known as Logistic Care, that offers rides to Medicaid individuals, but it's not just limited to Medicaid individuals. It's anyone who needs help with a ride. The number's listed there. People can call Monday through Saturday, 7 a.m. to 4 p.m. But they have to do a few things. They have to first schedule their vaccine appointment. They should schedule that before they call for a ride, and they need to call at least 48 hours before the vaccine appointment. And then also they need to be aware that the drivers will drop them off, and they'll be asked if they want to come back at 60 or 90 minutes. So they will have to hang out at the vaccine site. And we appreciate the flexibility of our vaccination providers to accommodate those folks. We know that was a change, but certainly the ability to offer transportation is huge. And then this other new resource, the community vaccination line that's available. You can see Monday through Friday, and then some hours on weekends to help people make appointments. It does not give them special access to appointments, but it helps people who might have difficulty booking an online appointment, language issues, maybe older adults who just have difficulty navigating. So it's a great resource, again, out there to help people book appointments. I mentioned we didn't have the Tuesday session last week, so with apologies for short notice on that for anybody who tried to join. Just a reminder that we do hold these DHHS health equity webinars monthly on the third Wednesday. So the next one will be Wednesday, April 21st. We are going to be switching these info sessions, hopefully as the information slows down. We're intending right now to switch them from weekly to twice a month. So we will hold next week, which is the 30th, but then starting in April, we'll go to the second and fourth Tuesdays. These health equity webinars will be held on the third Wednesday, so in between, and we'll keep sending reminders about that. folks can register anytime. And then folks, I'm sure, have seen the big update that the governor put out last week to escalate the timeline for vaccination. So starting today, we're now opening vaccine to anybody 50 and older. And then just about 3.5 weeks, April 19th, anybody 16 and older. And that's where, Amy just said, that's great news, but particularly that 16 to 18-year-old should only be getting Pfizer. We don't necessarily tell people what vaccine they're going to get right now when they register. So we're going to have to figure that part out. But clearly, very exciting and a big change. That's all based on a confidence that we will get more vaccine supply from the feds. So it is subject to availability to the supply, but that is the plan right now. Information always on the website. That website has been updated with that information about today being 50 and older, and then the 19th, 16 and above. Then information about the vaccination line is also now on the website, and we always post this info to the website and just contact info. So with that, I'm going to stop share and ask Amy or Dr. Sears if anybody's had a chance to tee up the questions in the chat. So we've got
Probably for Dr. Sears, are any statistics being kept on the number of people that get COVID after vaccination? And can you just talk a little bit about how the state and federal CDC are approaching that?
So you're still muted, Steve. There we go.
Oh yeah, you'd think I'd learn this after a year, but anyway, no,
it's a retirement thing. It's ruined.
But what I was saying is that yes, statistics are being kept, but they're only as accurate as people who report them to us. And so we ask that people, if they have a individual who, after 2 weeks after either the second dose of Moderna and Pfizer, or after the first dose of J&J, report that, and then there is an investigation. There is an attempt to get the virus if possible, and those are kept, and then they're being analyzed to see whether they actually are variants. But I do want to remind us that the vaccines are not perfect. So there's going to be some percentage of people who do not have a response. But I think the most important thing is almost all the ones I've seen are really fairly mild, if not asymptomatic. We've especially seen it in nursing homes. And I think it's important to recognize that the original trials were not done in nursing homes. They were done in elderly individuals. And the MMWR published a report, I think a couple of weeks ago, that suggested that in long-term care facilities, the rates might be more in the 65 to 70% effective range. Still very effective, but we're collecting that data, and hopefully we'll be able to get a better sense of that over time. The only other point is that Israel has this data on a population basis, and it shows that, at least for the Pfizer vaccine, that it's still, across the population, 92% effective overall.
Thanks, Steve. And Corey, this is a question for you. I feel like some of the hesitancy for pregnant women is that the CDC website and others are saying pregnant women should get vaccinated, yet there's limited data in the age group. So how do you approach that when your patients bring that up?
Yeah, absolutely. So we start by emphasizing that in general, vaccines are safe in pregnancy. We do have a lot of long-term research that shows this, and the only vaccines that we really avoid in pregnancy are the live virus vaccines. So theoretically, what we know about these vaccines, they should not be of risk in pregnancy. But we do, I put that all out there for my patients, and I say, this is the information that I have. I know that pregnant women are increased risk of severe disease. This is the safety information that we have so far coming in. This is the information that I don't have. And what is your risk of if you do get sick during pregnancy? And then I think it's also important to talk about what is an individual's risk. What do you do for work? How often are you out in the community? What type of comorbidities do you have? But it's shared decision making. And at the end of the day, it's up to the patient to make the decision. We don't have long-term data on this, but we do have long-term data on the safety of vaccines in general in pregnancy.
Great. And Steve, here's a
Can I interject just right there? So you told your own story, Corey, that you yourself were pregnant. Can you just talk a little bit about how did you feel about that? It's one thing for us to, I'm 60 years old, pontificate and say it's safe, but what was that like for you?
Yeah. I mean, in all honesty, when they began to talk about offering the vaccine to pregnant women, I said absolutely not. But I, the more I'm working in healthcare right now, everybody, I'm delivering women who are COVID positive. I'm doing emergency GYN surgeries on women who are COVID positive, and we're learning more and more about what the risks are in pregnancy when you have symptomatic disease. And then I spend a lot of time talking to people that I trust, people who are experts in immunology and virology. And I think as some of this was unfolding, a couple of my very trusted resources came out and said, there's no reason to suspect that there's going to be issues in pregnancy. And quite honestly, I've seen what happens when pregnant women have the severe form of the disease. And it's not, the people we expect, there's definitely the risk factors, but it's not always the people that we expect. So that's what I was weighing when I made the decision.
Great, thank you. It's your own version.
And Steve, this is probably the last question for the morning. Is there any new current recommendations around immunocompromised individuals and especially around vaccine advocacy?
Sure. I think it's an important question that's continuing to be monitored, but the federal CDC's guidance is that people who are immunocompromised should be considered for vaccination. You sort of have a double-edged sword in that those individuals are at higher risk for COVID and certainly COVID complications. They probably do not respond quite as well, but the problem is that I think we're going to have to break down ultimately into smaller definitions of immunocompromised, because there are people who are extremely immunocompromised. There are people moderately immunocompromised. But the bottom line is those people should be considered for vaccination.
Whoops, did we lose Amy? There we are.
Great. It's 8 o'clock, so probably we need to wrap up today. And then there's been some questions about the schedule. So there is another call Friday at noon, and next week there'll still be the Tuesday, Friday calls. And then after that in April, that's when they'll go to every second and fourth Tuesday and Friday. So next week there's still 2 calls.
Yeah, and I saw the question about getting a calendar invite. We generally have not done that for these because it's the same link every time, but I know with the Tuesday, with the second, fourth Friday, Tuesday, Friday, it gets a little confusing. So I will think about that and get back to folks next week. We have a lot of emails through the CME request, but not necessarily everybody. So we'll think about that and get back to folks next time with an update. Amy, do you want to just do quickly that school thing on 3 feet, 6 feet, or is that not quick?
Well, the state has always, since last fall, been at 3 feet between students, and then 6 feet if you're unmasked at lunch or between the teachers. So the guidance coming out on the federal side hasn't really changed what the main recommendations were, because they were using the Academy of Pediatrics recommendations. But the state is currently looking at the guidance that came out from the federal CDC on schools last week, and they will look to see whether or not they needed to update their guidance. And I think part of this is that the local school systems are going to need to look at, what they have for space available for schools. So it's a fairly complex issue, and we just, we'll adapt to what the federal CDC has put out. So
Great. Right, and it's now 8:02. So special thanks again to Dr. Corey Anderson for joining us today. Thanks so much. Best of progress with your pregnancy. It sounds like everything is going great. So thank you so much for joining us. Thanks, everybody. And again, we'll be doing our usual session here with Dr. Anderson again on Friday at noon, and this session again next Tuesday, and then we'll be switching the calendar from there. Thanks, everyone. Bye.